So welcome everyone and thank you for coming to the Choosing Wisely August webinar. I would like to begin today's webinar by acknowledging the traditional owners of the lands that we're on today. So I'm based in Melbourne and I would like to acknowledge the Wurundjeri people of the Kulin Nation and pay my respect to the elders past, present and emerging. So today I'm excited to hand over to Will Tumasimi, Caitlin Hardman and Juanita Breen, who will be presenting on the Antipsychotic Wisely project. We'll have the presentation first and then we'll have a few minutes for questions and answers at the end. So please feel free to post in the chat or in the discussion. Thank you.
So our presentation today is on Antipsychotic Wisely, which is looking at our project in which we investigated the prescribing in people admitted to hospital with dementia or delirium. My name is Caitlin Hardman and I'm the Senior Education and Training Pharmacist at Ipswich Hospital and a Conjoint Associate Lecturer at the University of Queensland.
And I'm Will Tumasimi and I'm the Drug Use Evaluation Pharmacist at Ipswich Hospital.
Hi, and I'm Associate Professor Juanita Breen. I'm an accredited pharmacist, worked in aged care for a long period of time and also researched psychotropic use at the Wicking Dementia Centre at the University of Tasmania. And I have to say I also work for the Aged Care Quality and Safety Commission.
Just to give you a bit of an outline of today's session, we're just going to talk about the impact that psychotropic medications can have on patients with dementia or delirium. Then we're going to jump in and talk to you about our project on the antipsychotic prescribing practices in the acute care setting. And then we're going to finish off with a bit of a discussion about antipsychotic stewardship initiatives that hopefully other Choosing Wisely Australia partners can embed within their own settings. So I just wanted to start off with a bit of
if someone is behaving or expressing something that's not to your social expectations or to your taste, medication is probably the most cruel thing that you can do to that person. It makes you feel more frightened because if your mind is scrambled and it feels like there's a flock of seagulls going around your head and all of a sudden someone is saying, well, here, let's put some more seagulls on. Let's make you more confused. Like, who is this helping? It's not helping us. You could be kind and compassionate and try to think, what might that pain be that that person is expressing? Is it physical? Is it emotional? How can we help them to maybe come to some peace with themselves? Let's look at some other ways.
So that's a bit of a moving patient's perspective and insight for health professionals on the use that antipsychotics can have. People with dementia or delirium have an increased vulnerability for agitation, aggression, and sleep disturbance. Although management with non-pharmacological strategies is recommended, clinicians commonly prescribe antipsychotics first line, despite a high adverse effect burden and limited effectiveness.
So Caitlin, how much of a problem is this? I mean, so if we have a situation where we can either use pharmacological interventions or non-pharmacological interventions, they sort of achieve the same ends of settling the patient down, does it really matter which one we go for?
Indeed it does. So the use of antipsychotics for dementia or delirium increases the risk of falls, cognitive decline, stroke and death. The Queensland Cognitive Impairment Management Toolkit and other best practice guidelines state that when prescribing antipsychotics, patient response should be monitored regularly, geriatricians consulted when possible, and there should be a documented discharge plan to guide ongoing review and deprescribing. Much focus has been directed at the use of antipsychotics in residential aged care, which has been highlighted by the Royal Commission into Aged Care Quality and Safety. There were testimonies of residents taking these medications for prolonged periods, often for several years and not the 3-month recommended for patients with dementia. Yet few researchers have actually examined prescribing practices of antipsychotics within the hospital setting.
Okay, so if we look at the slide on the screen here, we've got three main lines. We've got the orange line and the grey line, which basically indicate the proportion of antipsychotics which are dispensed to these patients. And the dotted blue line, which is vertical, that indicates when they actually go into residential aged care facilities. And what we can see from the slide here is that the lines are actually sloping upwards before the patients are actually entering in the residential aged care facilities. And so what that indicates to us is that it may not just be an issue in residential aged care facilities where they started on these medications, they may be starting on them beforehand.
Emerging evidence has suggested that hospitals may be contributing to this problem, as people may receive antipsychotics in the acute care setting for the first time before moving to their community dwellings or residential aged care facilities. What our research aimed to investigate was the antipsychotic prescribing in people with dementia or delirium on admission, during their stay, and upon discharge at a large regional hospital in Queensland. So, Will, how did we do this?
So basically, we audited a sample of 141 patients who are 65 years or older with dementia or delirium, who didn't have severe mental illness, who were prescribed antipsychotics. Our study found that over a third of people were already taking antipsychotic prior to hospital admission. This highlights the high level of community and residential aged care facility antipsychotic prescribing. What we also found was that of the 141 people who were included in the study, 103 or 73% were prescribed a new antipsychotic within hospital.
Wow, so that's alarming and not in a good way. It does appear that, like residential aged care facilities, hospitals are an area where the inappropriate prescribing of antipsychotics can be reduced. To answer your previous question, Will, this is why antipsychotic stewardship in the acute care setting is imperative. Professional guidelines, including the Queensland Cognitive Impairment Management Toolkit and other best practice standards, recommend that antipsychotics should only be used when non-pharmacological interventions have failed or if the person is at immediate risk of harm to themselves or others. Did the study look at the non-pharmacological approaches to care?
It did, and unfortunately the results weren't fantastic. So we found that over half of those who was prescribed an antipsychotic had no documented evidence of the use of these non-pharmacological strategies or treatment of the underlying causes of the changed behaviours. Our results imply that clinicians may be prescribing antipsychotic medicines as their preferred approach. In addition to this, only 29% had documentation of a review of antipsychotic treatment during their admission.
Best practice guidelines do state that when prescribing antipsychotics, patient response should be monitored regularly and geriatricians consulted for treatment reduction or cessation. Transitions of care are known as high risk for medication misadventure. Was there any evidence of a documented discharge plan to guide the ongoing review and deprescribing of the antipsychotics?
Yeah, so that was another area that we looked at. And what we found was that of the 141 people who were included in the study, nearly half were prescribed an antipsychotic treatment on discharge. Now, despite evidence that discharge is known to be an area of high risk for medication misadventure, unfortunately, management plans for antipsychotic review were virtually absent. Caitlin, this is an area of massive concern. Are there any tools out there that can help us help with our prescribing or management on a discharge?
Well, NPS Medicine Wise has developed a tool for reviewing and tapering antipsychotic medicines for patients with dementia experiencing the behavioural and psychological symptoms of dementia. This tool was developed to assist patients with long-term prescribing in a community or residential aged care facility. However, the use of a tool to facilitate multidisciplinary review of antipsychotic medications prescribed for patients experiencing changed behaviours, including advice on how and when to taper, can help to reduce the unnecessary antipsychotic prescribing.
Okay, so this looks like a really good tool that might be able to help us out in the discharge and within the transitions of care. But how about the acute care setting when the patients are actually in hospital? Are there any tools out there that we can use in that regard?
So currently there's no fit-for-purpose tool within the acute care setting to record antipsychotic details on discharge. One is being developed for residential aged care facilities by the Commission, but our future focus is to integrate a compulsory antipsychotic therapy checklist at the transitions of care to help increase patient safety and improve transfer of care upon discharge. Aged care homes have a very high regard for hospital care and are very wary of changing therapy as they feel that it's the gold standard. So assumptions made that GPs or aged care staff will review and alter therapy that has been started in hospital setting is actually misplaced. They are much more likely to continue the treatment because qualified specialists and clinicians started them.
So, Caitlin, this looks like very similar to the slide that you had in the last presentation that we did last month. We talked about, I guess, when we talked about opioid stewardship and that being a wicked problem, a sort of big problem, which is multifactorial, has lots of aspects, doesn't have a real clear kind of fix. Is this sort of similar to that? And how do we kind of approach it?
Look, I do like this picture. I think that it just helps to highlight that, yes, stewardship is a wicked problem and there's no easy solution or fix. It's complex, it's interconnected in nature, and it requires that multifaceted key stakeholder engagement. But I also think that it requires that element of design thinking and innovative approaches. So when you do input one intervention or strategy, it's not going to solve the whole problem as such.
All right. So this is, like you said, a big problem that we're sort of facing. So how do we even begin to start to try to address it?
Well, our study has shown that, like residential aged care facilities, hospitals are an area where the inappropriate prescribing of antipsychotics can be reduced. So it is highly likely we are inadvertently contributing to the issue of overuse of chemical restraint in aged care. A few take-home messages would be, from a prescribing level, the stewardship strategies would be to limit the prescribing. And so pharmacists, but also those in the multidisciplinary team, have a role in sort of advocating to not use antipsychotics as first-line therapy. We also need to consider frequent review, because what we're aiming to do is reduce and de-prescribe these prior to that transition to the community. The other really important aspect of this is the transparency of information on discharge. So trying to provide that systems level approach by mandating antipsychotic discharge plans from the acute care setting.
Okay, so those look like really good steps that we can take, but they sort of seem mostly directed towards prescribers. How about organizations? What should they do to try and address this issue?
So we can all reduce antipsychotic use at the level, as I said, with stewardship. It is multifaceted, so it can start from the prescriber level and everyone can make a difference. But from a perspective of an organisation and systems level approach, I suppose that in particularly within Queensland Health, they are expanding the digital platform with the integrated electronic medical records across the public hospital systems. And I think we really need to leverage off this electronic prescribing software with the integrated clinical decision support tools to try and nudge prescribing behaviour, not to continue these unnecessarily, but also to help to curb those inappropriate prescribing practices for vulnerable patients. Now, Juanita, you wanted to talk a bit more about the residential aged care facilities and also transitions of care?
Yes, please. I think the first thing is I am not a hospital pharmacist. I am an aged care pharmacist, well and truly, and a researcher as well. And one thing that I find interesting is that some people said, why are you involved in this particular project? And I think that the big thing is that for years and years, I've been told by aged care staff in particular that, look, we don't start these medications willy-nilly. What happens most of the time is they come in on it. And the thing is, they were saying mostly from hospital. And, you hear a lot of things, a lot of excuses, but it really came up again and again. And I think that first graph at the very beginning did show that there is an escalation of use before people are admitted to aged care. But we weren't able in this study to determine where people were discharged, people taking antipsychotics were discharged to. However, in the US, they have done studies, and I came across this particular one where they followed a large group of aged care residents, and they looked back and they actually could determine where the antipsychotics were started. Now, I did have little loops around the relevant data, but you can see in the results section about 19% of the antipsychotics were actually started in hospital. But what's interesting is that 18% of the antipsychotics were started in outpatient clinics associated with hospital. So really just under 40% of all antipsychotics were actually started around the hospital setting. And I think really, to be able to reduce use in aged care home, it would be great to be able to reduce use in hospitals so they don't come into aged care taking them. But I think, what we found in this particular study is a third of the sample did come in taking antipsychotics. About half of those were in the aged care setting, but half of them were also in the community, so prescribed initially by a GP. I think this whole hesitancy for aged care staff to discontinue antipsychotics is also shown in hospital staff or hospital registrars or geriatricians, because they were really wary to discontinue the antipsychotics as well. So there is this reluctance to stop what somebody else has started. What we did find is that half the sample, as we've shown, it's that Will and Caitlin were illustrating, were actually discharged taking antipsychotics, and very few were given a discharge plan. So we just really do need to work harder on communicating both sides. I think there's a lot more research that needs to be done on why guidelines for antipsychotic use to manage delirium and dementia aren't followed in hospitals. But one of the best things about this particular project was sort of the discussion that we had. Like, I was talking to secondary care or hospital pharmacists about our perceptions in aged care, and they were talking about their perceptions. And I think one of the main reasons they were theorising for use attitudes of staff and prescribers around safety of staff. Could have something to do with the lack of staff overall, limiting training, mentoring on non-pharmacological strategies, and of course on overall funding. But one of the most beneficial things I found was also sort of perceptions. Like I can say honestly that aged care staff have a high regard for medications that are started in hospitals. They think that it's usually done by specialists and that there must be a good reason for it. So they are very reluctant to change it. But also I found that even speaking to the pharmacists, they were saying that there are lots of pharmacists out there in aged care homes to do RMMRs, and I can tell you not at the moment. Maybe if we get embedded pharmacists in aged care, but on average we know that only about 20% of residents do have medication reviews, and usually we have restricted practice at the moment where we are only allowed to give most residents a review every year. If they get one at all. So that sort of whole reviewing doesn't really happen very commonly in aged care. So you can't sort of say that it's all going to be fixed when they get to the aged care home, because it won't be, not at present anyway. And that's my final comments. Thank you.
Thank you. Might hand back to you, Anne-Marie, if there's been any questions.
Great, thank you for such an interesting presentation. So if everyone can just post in the Q&A or chat section, then we can go through the questions as well. Just while we're waiting for questions, can you talk us through, I guess, what your organisation's next steps will be in relation to which actions you're going to follow up on?
Well, I'll take this one. So particularly from a local site level, education is one that we've implemented. So we've really sort of tried to target the junior doctors, because we found that from conversations, a lot of this initiation was happening after hours. So education has formed a big part to try and curb those prescribing practices and to really get them to think about that. We've also engaged with the core teams that have that we identified within this study that were contributing to the overuse of the antipsychotics. So again, that educational arm. But what we're really looking at doing as a second step, which we are hoping will help particularly that transition of care, is integrating an electronic discharge form for the antipsychotics. So if patients are going home, even be it a PRN, so when required, or any antipsychotic, that there is a plan to ensure the judicious use, but also deprescribing. The other things that we've done is heavily liaised with the nursing staff with respect to the non-pharmacological strategies, and having those sort of campaigns and education and empowering them to make sure that they're putting that person-centred care first prior to that pharmacological therapy.
Great, thanks, Caitlin. Looking forward to the results from those actions as well. Okay, so we have a few questions that have come through. One's from Len Cam. Did your study look at appropriateness of prescribing?
Will, did you want that one? Just talk about our inclusion and exclusion criteria.
Yeah, so we tried to narrow it down to the patients that you would expect, well, that you could say could be prescribed these medications. So that's why we looked at patients who are over 65 and over 45 for Indigenous peoples. We also excluded patients who had severe mental illness as well. So just to sort of eliminate that as a confounding factor. In terms of appropriateness, I guess that's why we looked at non-pharmacological interventions to really see, are they sort of having that escalation? Are they trying the non-pharmacological approaches first before sort of jumping to using antipsychotic treatments? And also, were they using it in the context of the
defined behaviours that warrant after escalation? So things like vocalization, are they making sure that it is appropriate for the indication of the behaviour that the patient is exhibiting? So we did look into that, obviously acknowledging the limitations being the extent of the documentation, but prior to intervention with chemical restraint, obviously we need consent, but also we need to make sure that de-escalation non-pharmacological strategies have been sort of applied. So in regards to appropriateness, I would say that we did look at that, noting some limitations.
All right,
thanks for jumping in there, Caitlin.
Yeah, that's okay. Sorry, I didn't know how long that was going to go for.
So Will and Caitlin are well and have still presented, so thank you both. So Marion Spence, great presentation. Thanks, powerful message at the start from Teresa Flavin. She's just asking if you can share the link to the video.
Yeah, no problem. So I think that does come up on Dementia Australia, but I'll pop it into the chat now.
Great, thank you. And the other resource that NPS Medicine Wise developed as part of that campaign with that video as well is a behaviour change diary. So that could potentially be useful for implementing patient-centred care. So I'll share the link to that. So it basically has patients' likes, dislikes, hobbies, to ensure that it's patient-centred when those non-pharmacological approaches are used. Okay, so next question. What do the panel see as key components to include in an antipsychotic discharge plan from acute settings?
It's probably your expertise, Juanita, being in the transition care, residential aged care.
I think it would be really, really helpful to say exactly why it was prescribed and for how long it's supposed to be prescribed for. Because I think if you had a use by date, that would really help people. Just to sort of say, look, we recommend, this be reviewed with a view to cessation in a week or two, if that's, and we know that the maximum time people are supposed to be taking an antipsychotic after delirium is no more than 1 week, and that really needs to be sort of stressed.
Thank you, Juanita. Okay, so from Deanne Birch, do many health services have restrictions on who can initiate antipsychotics for BPSD or delirium? Our health service does, but find that a number of the junior medical staff are not aware that this is a danger.
Yeah, I would have to agree with that. So despite having those restrictions or guidelines on the initiation and having a geriatrician involved, we did find that in certain settings it did start or was initiated, and more often than not, and this was outside of the scope of the study, but it was from conversations that have been had from that educational intervention that we've implemented after, that it is in those sort of ward call situations, after hours, junior clinicians not experienced in the area of geriatrics or dementia or delirium, but also, as Juanita did mention, that sort of all about staff safety and all about making sure that we keep our staff safe, but there is an underlying perception that chemical restraint is for all behaviours that a patient with dementia may experience, and that there's perhaps staff that aren't trained in those de-escalation strategies or person-centred care, which is very hard in the hospital environment to implement, but yeah. Would love to know how we restrict that further.
Next question. So how is non-pharmacological methods documented, and is there a standard note you have in the hospital?
So unfortunately, there's not a standard note that we have, and I guess that's one of the limitations of our study as well. Because I guess if we ask the nursing staff, they may say, "Oh yeah, I did try the non-pharmacological interventions, but I just didn't write it down." Whereas our response will be, you should be documenting it, because how does another prescriber know what the escalation pathway has been, and like what has been tried beforehand, and what are you communicating to your other colleagues as they sort of take over the care of the patient as well? So there was no specific standard note in the document. We just had to read through the notes to see if there was any mention of the non-pharmacological interventions.
Juanita?
Yeah, I was just going to say it's very, very easy to measure antipsychotic use or a medication use. It's much harder to actually document non-pharmacological strategies because they are broadly defined. Some people say any sort of assessment is a non-pharmacological strategy. You could argue about that or not, but that's one of the strengths of this particular study, that we did try to look at the documents and the records to see whether there was any record of non-pharmacological strategies at all.
That's a good point. Okay, from Jaxie Johnson, which antipsychotics specifically did you see used the most, at what doses, and how long were they on it for?
Just on that, I am popping in the chat the article that we published in the Australasian Journal of Aging, which does detail more specifics, just cognizant of everyone's time. So, Will, did you have any comment with respect to?
So basically, risperidone was the most one that we saw. In terms of how long that they were on it for, we only really looked at specifically within the hospital setting that they were in. So we didn't sort of look at how long they were on it before or how long they would have been on it afterwards.
Are there barriers from the aged care facility point of view, having locum doctors review residents transferred back from hospital, as these often happen after hours? Are follow-ups lost due to this, residents not having a regular GP or regular GP visits, etc.? So, Juanita, I think you had your hand up.
Yeah, where do you start? Look, it's variable from aged care home to aged care home and their policy, but a lot of the time, we do know that transitions of care is a really problematic time. There has been a recommendation to have a coordinator or a role for somebody to identify a person with cognitive impairment at an aged care home, and both ways, going into into hospital, so the hospital knows why they're taking that particular medication, but also when they're discharged as well. And it is really hard, and it's so hard getting GPs to come into aged care homes. And again, the arrangement is really different from facility to facility as well. Some of them have a principal GP, some of them have 70, 80 GPs, and it's an area that the Royal Commission really highlighted as being particularly problematic, and there's also been a lot of research funding just recently allocated to really do something about this particular period of time, because it's fraught.
Thank you. So we have another 3 questions and a comment, and then if anybody else has more questions, maybe just email it to choosingwisely@nps.org.au. So the next question: Is there anything that you think that pharmacists could do better in the acute setting rather than interventions on discharge?
Yes, advocacy. So advocacy for the patient, for those non-pharmacological strategies. So I think education as well, despite it being a hot topic for numerous years, I do think that there's still clinicians and potentially teams within the hospital setting which are sort of not understanding the risk or benefit ratio. So I think that one falls down to education, but also advocacy for the patient, which is why I think that's a really moving video from Teresa Flavin.
Mm-hmm. And then we've got Chris Leong, fantastic presentation. Wouldn't it be wonderful if hospital and community GP EMR were integrated? Any thoughts on how this could be done? Thanks once again.
Will, IT?
That's a big problem. And I think that's a really good suggestion. Integration of electronic systems is really the way forward. It'll be great if, as soon as information was put into the hospital and they were discharged, that it was able to be accessed straight away in one sort of central point where everything was. And that's kind of like the dream, really, in terms of access of information. In terms of how it can be done, that's a big issue. That's sort of a way above our pay grade, and where we're kind of sitting at this more of a sort of state and sort of national level, trying to integrate different systems. But I take your point that would really help solve a lot of these problems. Not solve the problems, but really help us along the way, especially with communication.
And I have heard that NT Health are doing a project on this. So, and if it's successful, it may be rolled out. So very early days though. Okay, so Deanne, again, I'm struggling to find an effective behaviour assessment or chart and care plan for use in hospitals. Could you point me in the right direction?
With this one, Deanne, I don't have it on the top of my head, but I have had conversations with our clinical nurse consultants in our geriatric ward. I'm happy to. I'll provide you my email, and you can we can be in contact. Thank you.
Thank you. So Janice has just made a comment. So she said she's agreed with what's been said regarding aged care sector being respectful of acute sector prescribing. And then the challenge for us in aged care is that it's nurses and not the prescribers required to take the leadership role in the stewardship, which is a challenge. I definitely agree with you there, Janice. Any comments from any of the presenters on that? Juanita?
Yeah, I think it's really good for a nurse to sort of say we need to take the responsibility, because I think a lot of the time you do hear from aged care staff, well, look, we haven't got the pen in our hand. We're not the one that writes these prescriptions. But, if you talk to prescribers, they don't visit aged care homes a lot, and they rely almost exclusively on the staff for assessments about behaviour. And they will tell you, look, often the staff ask us for these medications. And I don't know whether that happens in hospital as well, but I suspect it does, because the nurses are the ones often that are there on the ground, and they sort of have to assess behaviour but also manage behaviour as well. So I sort of think it's a really good comment to say that, nurses really do need to take the lead in psychotropic stewardship. I would also advocate that, pharmacists are, we're the experts in medication management, and we need to take an active role as well in helping to review, again, advocacy, foster the use of non-pharmacological strategies, but also when these medications are used to monitor, with the view to using the lowest effective dose for the shortest period of time, and really try, to reduce as much as we can at regular intervals.
Thank you, Juanita. So I think someone asked about the recording. This is recorded and will be uploaded to the Choosing Wisely website. If you have trouble finding the page, just email choosingwisely@nps.org.au. I've posted a couple of links in the chat with some resources that may be useful that were developed as part of the NPS Medicine Wise Dementia program as well. Caitlin?
Yep, someone did ask a question in the chat about resources to help education and upskill pharmacists. Dementia Training Australia has a wealth of resources, short webinars, interactive activities. Juanita, are you aware off the top of your head of any other programs that we can direct people to upskill?
There are. I do know at the Aged Care Quality and Safety Commission there are a number of pamphlets and resources, and we also speaking my own work or work with my team, we also have a nice 6-minute video on reducing the use of psychotropics in aged care, and it does actually specifically say, and I have to give credit to sort of this research for really including this, is that when people come in, you can't just say, oh, it started by somebody else. There must have been a really good reason for it. If they come in, and it's a good opportunity to review and to sort of with the view to deprescribe, rather than sort of saying, well, there must be a good reason, we'll just leave them on it for a period of time. Yes,
definitely. The other resources that may be useful on the NPS Medicine Wise website, there's some videos on non-pharmacological approaches that are really practical. So we use that to train nursing staff. So they're by Dr. Lynn Chenoweth. So have a look at that. The behaviour diary also has a behaviour assessment chart on the back of it. And we know the 5 questions, the Choosing Wisely 5 questions, were a really useful conversation tool when having that discussion about informed consent as well. So, heaps of resources there. If you do want to follow up with anything, please do just email choosingwisely@nps.org.au. I think Caitlin also put her email up there somewhere, but if not, we can always put you in touch with her.
Sorry, I just sent that one privately, but yeah.
Oh, okay, sorry, yeah. Thank you, everyone. It's been a really robust discussion, and we will see you in September for our next webinar. So that will be on the 21st of September. Just a big thank you to Juanita, Caitlin and Will, especially for not pulling out last minute when you're so unwell, and also for sharing your work in such an important area. Thank you, and see you next time.